No discussion of obesity would be complete without some mention of some of the new medications that are used to treat obesity. I'm sure most of you have heard about some of these drugs just by watching the news or watching TV commercials, or perhaps knowing people who are using these medications for weight loss or for treatment of type 2 diabetes. So far in this class, we've really only mentioned one approved drug for aiding in weight loss. That drug was orlistat, which is sold under the brand name Ally. As you may recall, orlistat aids in enhancing weight loss by inhibiting pancreatic lipase activity in the GI tract. But we also talked about some of the problems with this drug, which greatly limited its popularity as a weight loss medication. But over the past several years, there's been a whole new class of weight loss medications that have been approved and have quickly become very popular. These function in an entirely different way than drugs like orlistat. Many scientists and physicians believe that some of these drugs represent the future of obesity treatment and weight loss management. In this video lesson, we're going to look at some of the most popular of these drugs that belong to a class known as GLP-1 receptor agonists. Before we get into a discussion of some of these medications, we first need to present some basic introductory information. As I mentioned just a moment ago, these medications belong to a class of drugs known as GLP-1 receptor agonists. So that, of course, begs the question, what is GLP-1? GLP-1 stands for glucagon-like peptide. The fact that this is known as GLP-1 suggests that there must be a GLP-2 as well, and that is true. But GLP-2 has very different function in the body than GLP-1. Both GLP-1 and GLP-2 are produced by L cells in the intestinal tract. L cells are simply enteroendocrine cells found in the gut, predominantly in the ileum or distal small intestine, and the colon. These cells secrete various hormones. The primary function of GLP-2 is to stimulate the growth of intestinal epithelial cells and intestinal villi. These are the main sites where nutrients are absorbed, as you may recall from our discussion of digestion. But GLP-1 has very different biological functions and activities. As we will see a bit later in this video lesson, GLP-1 functions to stimulate insulin release from the pancreas and helps to control blood sugar, and it also suppresses glucagon release from the pancreas, which would otherwise raise blood sugar. It has many other biological and metabolic functions, as we'll see as well. But its role as a compound that stimulates insulin release from the pancreas puts it in a class of substances known as incretins. Incretin is just a term to describe a group of hormones that are released by the gut in response to food intake and that function to increase insulin secretion and inhibit glucagon released from the pancreas. We discussed one of these incretins a bit earlier in our digestion video lesson. The hormone GIP, which stands for glucose-dependent insulinotropic polypeptide, is also an incretin hormone. As you may recall, among its functions is the delaying of gastric emptying and the stimulation of hydrochloric acid release in the stomach. But in this video lesson, we're going to focus on GLP-1. One of the first things that's very interesting about GLP-1 release in the gut is that most of it originates from L cells in the distal small intestine, the ileum, and the colon. And yet you will see a rapid rise in serum levels of GLP-1 soon after consuming a meal and long before food would reach the ileum or colon. This clearly suggests that the stimulation of the L cells to release GLP-1 is occurring by a mechanism separate from exposure to the food in this portion of the intestinal tract. So there are other neuroendocrine stimulators that are signaling the L cells to secrete GLP-1 soon after consuming a meal. The other very interesting point to note about GLP-1 is that it has a very short half-life. It only persists in circulation for a few minutes. Here I'm indicating less than 2 minutes, but it could be anywhere from less than a minute to up to 5 minutes. In either case, it disappears very shortly after it is released. So it exerts its effect on the pancreas and other tissues over a very short period of time following the consumption of a meal. And so that presents one of the first challenges to considering GLP-1 as a diabetes or weight loss medication. We'll talk about how this issue was addressed by drug manufacturers in a few minutes. So, what is the structure of GLP-1? GLP-1 is a 30 amino acid polypeptide. Here I'm indicating that it's referred to as GLP-1 parentheses 736. The 736 refers to the fact that the first amino acid shown here as histidine is designated as amino acid number 7 in the sequence, and that the last amino acid is arginine, designated as amino acid 36 in the sequence. It's referred to this way because when this polypeptide is first synthesized in the cell, it contains 6 more amino acids in front of the histidine amino acid. But those are removed post-translation to yield the biologically active form shown here. There's another GLP-1 form that has similar biological activities, but differs very slightly in the amino acid sequence at amino acid number 36 and 37. But GLP-1 736 is the most prominent form found in the plasma. The fact that GLP-1 was recognized early on to stimulate insulin release from the pancreas and inhibit glucagon release from the pancreas made it a tempting target for the development of drugs that could be used in the treatment of type 2 diabetes. It certainly would not be a difficult challenge to synthesize this small, simple 30 amino acid sequence peptide and then inject it into animals and look at what effect it has on glucose control. But the extremely short half-life of native GLP-1 would still greatly limit its usefulness in the treatment of type 2 diabetes. Why is the half-life of native GLP-1 so short? GLP-1 is rapidly broken down by the enzyme dipeptidyl peptidase 4. This enzyme is produced primarily in endothelial cells lining blood vessels and epithelial cells in the intestinal tract. The enzyme is shed from these cells into the bloodstream or into the intestine. Thus, much of the GLP-1 that is produced by the L cells is already being broken down in the intestinal tract even before it can reach the general circulation. And then once it reaches the general circulation, it is again broken down by DPP-4 enzymes being produced by endothelial cells lining blood vessels. So if drugs are to be designed around the structure and function of native GLP-1, it will be necessary to inhibit the activity of DPP-4 in order to increase the half-life of GLP-1 and make it a viable type 2 diabetes medication. In fact, there have been drugs developed that target DPP-4 and inhibit this enzyme, but they only resulted in modest improvement in GLP-1 half-life. Nevertheless, some of these drugs were approved for treatment of type 2 diabetes and have shown improvement in insulin release from the pancreas, delayed gastric emptying, and reduction in appetite. One drug that I recall being sold for this purpose was a drug known as Januvia. But there was still an interest in finding a way to significantly increase the biological half-life of drugs built around the GLP-1 structure. That led to drug companies developing various modifications of the GLP-1 structure. The one that we are going to focus on primarily in this video lesson is the GLP-1 receptor agonist drug known generically as semaglutide. At this point, it's probably worth reminding everyone what is meant by a receptor agonist. A receptor agonist is simply any compound that activates a particular receptor on a cell. In this case, we are obviously interested in activating the receptor for GLP-1. Well, certainly native GLP-1 activates the receptor when it interacts with the receptor on a target cell. But as I already mentioned, the half-life of native GLP-1 is so short that the stimulation of the receptor does not last very long. Drug companies wanted to find a way to maintain that stimulation of the GLP-1 receptor by greatly increasing the half-life of the GLP-1 receptor agonist drug, in this case, the drug semaglutide. So how did they do this? The first thing that researchers did was substitute the alanine amino acid in position 8 of the sequence with an amino acid known as alpha AIB. Alpha AIB stands for alpha amino isobutyric acid. This is a non-proteogenic amino acid, which is just sometimes used to modify an amino acid sequence. But by substituting the alanine with this non-proteogenic amino acid, it prevents semaglutide from being enzymatically degraded by DPP4. The second modification that researchers made was to add an 18-carbon fatty diacid chain to the lysine residue at amino acid number 26. A fatty diacid chain is simply a fatty acid compound that has a carboxylic acid group on both ends of the chain. In this diagram, the carboxylic acid on the right side of the chain is attached to a spacer molecule, which is attached to the epsilon amine group of the lysine residue at position 26. By adding this long-chain fatty acid to the semaglutide molecule, it allows this molecule to bind to serum albumin in the blood and minimize its clearance and excretion in the urine. And the third and last modification to the structure and the development of semaglutide was to replace the lysine residue amino acid at position 34 of the polypeptide chain with the amino acid arginine. This prevents that fatty diacid compound from binding to the wrong lysine site in the semaglutide polypeptide chain. You'll notice as you look at the 30 amino acids in the GLP-1, there are only 2 lysine residues in the chain, one at position 26 and one at position 34. We want the fatty diacid chain to attach only to the lysine at position 26 and not to the one at position 34. So we replace the lysine residue at position 34 with arginine. The result is we now have a biologically active variation of native GLP-1 known as semaglutide that has a serum half-life of now nearly 1 week rather than just a minute or two. But we have to remember, of course, that we are still dealing with a polypeptide compound. And so in order to achieve this half-life of approximately 1 week, it'll be necessary to deliver this drug via subcutaneous injection rather than by the oral route. That's because, as I'm sure you can appreciate, ingestion of this compound via the oral route would result in its rapid breakdown by acid and peptidase enzymes in the stomach. We'll talk about this issue a little bit more in a few minutes. But for now, it's simply important to note that this version of semaglutide must be administered via subcutaneous injection. Let's now spend a few minutes talking about all the various ways that a GLP-1 receptor agonist like semaglutide can affect metabolism in various tissues. Let's start by looking at the gut itself. GLP-1 receptor agonists will slow intestinal motility as well as decrease lipoprotein secretion, specifically inhibiting the synthesis and release of chylomicron particles from the intestine. In fact, following administration of these drugs, lower postprandial levels of triglycerides, VLDL, and apoprotein B48, which is a marker of chylomicron synthesis, are noted in the serum. With regard to the liver, you see a decrease in glucose production and release from the liver, and we see a decrease in steatosis, which is simply the synthesis and accumulation of fat in the liver. In the brain, we note an important decrease in appetite and an increase in satiety as a direct result of GLP-1 receptor agonists' effect on the hypothalamus. With regard to the heart, there are numerous cardioprotective effects of GLP-1 receptor agonist administration. We'll talk in more detail about some of these a little bit later in this video. In addition, there can be important changes in fatty acid and lipid metabolism in the heart, including an increase in fatty acid oxidation, reduce lipid accumulation, and improve mitochondrial function, all of which can be beneficial to cardiac health. In the kidneys, semaglutide drugs can increase kidney diuresis, and this can be beneficial in terms of reduction in serum sodium levels. In the pancreas, an extremely important organ related to the beneficial effects of semaglutide drugs, these drugs increase insulin secretion and decrease glucagon secretion. In addition, beta cell proliferation is increased and beta cell apoptosis is inhibited. The end result is an increase in insulin-producing beta cells. The effect of semaglutide drugs on adipose tissue are also very interesting. In addition to increasing the uptake of glucose in adipose tissue, semaglutide drugs have also been shown to stimulate brown or beige adipose tissue thermogenesis. I'll talk a bit more about this in just a moment as well. Semaglutide also slows gastric emptying in the stomach, as well as stimulating acid secretion in the stomach. The slowing of gastric emptying helps extend the feeling of being full, and therefore contributes to the reducing of food intake. In muscle, semaglutide improves glucose uptake and improves perfusion rates within the muscle. This increased perfusion rate is associated with an improvement in the function of the endothelium, the inner lining of blood vessels. This can lead to enhanced vasodilation and better blood flow. The improved endothelial function can also reduce the risk of atherosclerosis and can promote muscle synthesis and improved exercise performance. Let me say just a little bit more about the role of GLP-1 receptor agonists on adipose tissue, particularly brown fat. As I already mentioned, semaglutide can improve glucose uptake in adipose tissue. And this is not surprising given the fact that semaglutide improves insulin sensitivity, which is critical for glucose uptake and metabolism in adipocytes. It's also important to note that semaglutide can increase thermogenesis in beige and brown adipocytes. The mechanism for this activation of thermogenesis is at least partly related to the relationship between the hypothalamus in the central nervous system and the interaction with brown fat. In this slide, we can see that target neurons in the hypothalamus and the central nervous system contain GLP-1 receptors, and when activated can stimulate brown fat activation and thermogenesis, as indicated here in the blue boxes. It's worth noting in these red boxes that GIP, remember that's glucose-dependent insulinotropic polypeptide, also plays a role. It increases glucose branched-chain amino acid and lipid catabolism, and it increases the tricarboxylic acid cycle. It improves insulin sensitivity, and it results in the increase in circulating branched-chain amino acids and branched-chain keto acids, and it increases the expression of thermogenic genes important for the synthesis of uncoupling protein. This all should be somewhat familiar to you from our discussion of brown fat metabolism in an earlier video lesson. The end result is a potential increase in energy expenditure as a result of increased thermogenesis in brown and beige adipose tissue. If you've ever seen any of the television ads for the weight loss semaglutide drug Wegovy, you may have noticed that they highlight three important potential benefits of this drug. One is weight loss, two is reduction in hemoglobin A1C levels, and three is reducing cardiovascular risk. In this slide, I want to talk a little bit more about that last point related to cardioprotection. What are some of the ways that drugs like semaglutide reduce cardiovascular risk? This is a bit of a busy slide, but I want to highlight some points. In the top center, you can see the semaglutide structure, and the first thing that you note is that it can increase satiety and decrease appetite by interacting with the brain. That would be expected to result in weight loss, which itself represents a cardioprotective effect of the drug. In addition, on the top right, we can see the effect of semaglutide on the pancreas, resulting in an increase in insulin secretion and a decrease in glucagon secretion. The effects of increased insulin and increased insulin sensitivity can have some direct effects on heart health, including improving myocardial contractibility, improving cardiac glucose uptake, increase in heart rate, and increase in ischemia tolerance. In addition, semaglutide can have direct beneficial effects on blood vessels indicated in the center of this graphic. These include an increase in endothelial function, an increase in plaque stability, and an increase in angiogenesis. These are terms that should be familiar from our discussion of atherosclerosis in an earlier video lecture. In addition, semaglutide can result in a decrease in vascular inflammation, a decrease in arterial stiffness, and a decrease in platelet aggregation, all of which contribute to the cardioprotective effects of this drug. As I mentioned earlier, GLP-1 receptor agonists can improve kidney diuresis, and that may result in an increase in sodium excretion, which is associated with reduced high blood pressure, which therefore can also contribute to cardioprotection. And in the lower right, we can see that GLP-1 receptor agonists can reduce insulin resistance in various peripheral tissues, including the liver, muscle, and fat, and can reduce liver fat accumulation, as we mentioned earlier, and can reduce peripheral inflammation and reduce pro-inflammatory cytokines. So this slide does a nice job of summarizing all the various ways that semaglutide drugs can contribute to a cardioprotective effect. So far, I've been focusing on the drug semaglutide. There are other GLP-1 receptor agonist drugs approved and on the market. I'm not going to talk too much about any of these other drugs, but I do want to point out a couple of things from this chart. First, at the very bottom, you'll notice the drug Mounjaro, and under the generic name trizepatide. This drug is interesting because it is a dual incretin drug. It contains both GLP-1 receptor agonist as well as a GIP receptor agonist. So it may offer some additional advantage over just GLP-1 drugs like semaglutide. The other thing I want to point out about this chart are the drugs Rybelsus and Wegovy. Rybelsus is an orally administered semaglutide drug approved for the treatment of type 2 diabetes. An orally administered form of Wegovy is also now approved for weight loss treatment. Very recently, another GLP-1 weight loss drug was approved by the FDA. Foundayo, with the generic name orforglipron, was approved by the FDA earlier this year in April, I think. I'll talk a bit more about how effective oral administration of these drugs is accomplished in a few minutes. And the last thing I want to point out from this chart are the two drugs Ozempic and Wegovy. Both of these drugs are produced by the Danish drug company Novo Nordisk. One, Ozempic, is approved for the treatment of type 2 diabetes. The other, Wegovy, is approved for weight loss. Let's talk for a minute about the difference between injectable versions of these two drugs. As you can see on this slide, both Ozempic and Wegovy are sold with pre-dosed subcutaneous auto-injector pens. So they are both administered by subcutaneous injection. So what's the difference? Well, there really is no chemical difference between these two drugs. Chemically, the drugs are identical. Ozempic was approved by the FDA for the treatment of type 2 diabetes in 2017. Wegovy was approved by the FDA for the treatment of weight loss in 2022. The only real difference between these two drugs is in the dosing recommendations. They vary slightly. So Wegovy and Ozempic are the two name brand drugs that you hear about all the time in television ads, for example. These are not inexpensive medications, but some of you may know of people who have been taking semaglutide drugs other than these authentic name brand names. Many of these non-brand name drugs are much less expensive. But Ozempic and Wegovy still have active patents in place that protect them from competition from much less expensive generic versions of these drugs. So how was it possible that these cheaper non-brain versions were available? Let's look at this point a bit more closely. As I mentioned a few moments ago, Ozempic and Wegovy are manufactured by Novo Nordisk, a pharmaceutical company headquartered in Denmark. Its semaglutide sales for Wegovy in 2025 were over $7 billion. That represents 52% of all of this company's total sales. The US patent for Wegovy does not expire until the year 2032. Its patent on this drug expires sooner in some other countries. For example, the patent expires in China sometime in 2026. So we should not expect a generic version of Wegovy in the United States until after 2032. It's unclear how China's patent expiration in 2026 will affect international sales and availability of a generic version in other countries after 2026. But clearly there's a lot of money at stake for Novo Nordisk. The list price for a monthly supply of Wegovy is about $1,350 per month. However, it should be noted that depending on insurance and other discounts, most patients are eligible for a significant reduction in this cost, perhaps down to less than $500 a month. Still, this is much more expensive than many people are currently paying for non-name brand versions of this drug. The reason that many people were able to obtain much less expensive versions of this drug is because up until recently, the FDA permitted this drug to be formulated from generic ingredients by so-called compounding pharmacies. What does this mean? It means that under special circumstances, the FDA may permit a drug to be formulated by small pharmacies, even if the drug is under protected patent by a drug manufacturer such as Novo Nordisk. What are the conditions that must be met for a drug to be allowed to be formulated by a compounding pharmacy? There are two possible reasons that the FDA may allow this. One is if there is a need for a specially formulated version of the drug by a particular patient. So, for example, if a patient needs a drug and the name brand version of the drug contains an ingredient that a patient cannot be exposed to, they may be allergic to a coating or something, then the FDA would allow a compounding pharmacy to produce a custom version of that drug without that ingredient. That would be known as a compounded drug. The other reason that the FDA may allow a drug to be compounded is if there is a shortage of the name brand drug. When Wegovy was first approved in 2022, Novo Nordisk was not able to keep up with the demand for the drug. So the FDA declared a shortage of this drug and allowed compounding pharmacies to produce it during this shortage, particularly immediately following the COVID pandemic supply chain disruptions. However, effective May 22nd of 2025, over a year ago, the FDA no longer considers Wegovy to be in short supply and thus now prohibits the sale of compounded versions of this drug for this reason. I know that there are some court challenges to this FDA decision that are currently working their way through the legal system. But as of now, as far as I know, the less expensive compounded versions of the authentic drug are not permitted for sale in the United States. So far, we've spent a lot of time talking about some of the very promising benefits of GLP-1 receptor agonists, like semaglutide, on type 2 diabetes and in the treatment of obesity. But we should not ignore the fact that these are powerful drugs and they have potential serious side effects. They also have some possible less serious side effects. Let's start with a review of those first. One of the most common side effects to these drugs, particularly when first starting these medications, is nausea and sometimes vomiting. In most cases, the nausea is mild to moderate and tends to lessen over time as your body adjusts to the medication. This is also the reason that the medication dose is typically titrated up from a low dose at first to minimize some of these early side effects. Some users may also experience diarrhea when they first start this medication, and that also usually subsides as your body adapts to the drug. Constipation can also be a side effect, so it's important to stay hydrated when taking this drug. Some abdominal pain may occur, especially when first starting the treatment. and there may be some abdominal bloating or distension, likely due to the medication slowing down stomach emptying. In addition, some humans report feeling tired or experiencing a lack of energy when starting the drug. And others have reported headaches when taking the drug. Again, this may be due to the dehydration associated with taking the drug in some people. Of course, decreased appetite is also a side effect of the drug, but presumably that's the goal. However, with the anticipated decrease in appetite, it is still important to ensure that you have adequate nutrient intake while taking this medication. Some people report excess burping and belching that can occur as the body releases excess air from the stomach. And heartburn can be a side effect of this medication, likely related to the slowing down of stomach emptying that can contribute to acid reflux. In addition, some users report changes in vision, including blurred vision. This may be related to rapid changes in blood sugar levels that can sometimes lead to temporary vision changes. And finally, there can be injection site reactions, including redness, swelling, or pain at the injection site. But this drug is typically administered with a very small gauge needle, and so this side effect is rather uncommon. There are some potentially more serious side effects that can occur as well, and these need to be carefully monitored. These include kidney damage, which may be secondary to dehydration from the gastrointestinal side effects and the increased diuresis in the kidney. In addition, severe stomach pain, nausea, and vomiting or fever can be signs of gallbladder issues like gallstones. There's been some indication in animal studies that these drugs can increase the risk for thyroid C-cell tumors. So far, there's no evidence that this has occurred in humans. Nevertheless, individuals with a history of medullary thyroid cancer should not use this drug. Pancreatitis, or inflammation of the pancreas, may occur in very rare circumstances. Severe stomach pain that radiates to the back should be reported immediately to your physician. And finally, severe allergic reactions are possible, although very rare. Symptoms such as hives, swelling of the face, throat or face or throat, or difficulty breathing require immediate medical attention. So far, we have been focusing on subcutaneous injection forms of semaglutide. For the patient, this typically means weekly self-injections. There's a lot of interest in the development of oral versions of these medications. So far, only one of these semaglutide drugs has been approved for oral administration in the treatment of type 2 diabetes. That drug is Rybelsus. As mentioned earlier, 2 other oral drugs have been approved for treatment of obesity, Wegovy and Foundayo. As you can imagine, developing an oral version of this polypeptide hormone presents some significant challenges. How do you protect this 30 amino acid polypeptide from the acid and pepsid degradation effects in the stomach so that it can ultimately be absorbed into the bloodstream? I don't know for sure how manufacturers accomplish this, but I can describe studies in the literature that describe how this can work, and these oral versions of the drugs likely use some variation of these methods. One way is to encapsulate the active drug within a material that protects the active drug from being broken down by acid and enzymes. In this slide, you can see that the active ingredient is encased in a compound abbreviated SNAC, which stands for sodium N-A2 hydroxybenzoyl aminocaprylate. That's quite a mouthful, so we'll just refer to it as SNAC. SNAC neutralizes the pH of the gastric fluid only immediately around the capsule, so it doesn't neutralize the acid content of the stomach in general, just in the area immediately surrounding the capsule itself, and therefore protects the semaglutide from proteolytic degradation from acid and enzymes. The SNAC also facilitates the transcellular absorption of semaglutide across the gastric mucosa. So the drug is absorbed in the stomach, not in the small intestine. Still, even with this modification to protect the active drug from breakdown in the stomach, the total absorption of the drug across the gastric mucosa into the bloodstream is still relatively low. This is clear when you look at the difference in the dosing recommendations for the drug via injection, like Ozempic, versus the drug in the oral route, with Rybelsus. Ozempic can be taken by injection at a recommended dose of up to 2 milligrams per week via a once-a-week injection. Rybelsus would be taken orally at a dose of 14 milligrams every day. That adds up to a total of 98 milligrams taken orally per week, compared to 2 milligrams taken by subcutaneous injection per week with the Ozempic injection. So the total dose administered in the oral route is 49 times higher than it is with Ozempic via the injection route. Nevertheless, many people are still uneasy injecting themselves with the medication. And so there is still a lot of research going into the development of better oral versions of these drugs. So what is the future of these medications in terms of treatment for obesity? Clearly there's still need for much more research, particularly on the long-term effects of taking these drugs. Ozempic has now been approved for over 7 years and has been taken by many millions of people over that time. So a lot of relatively long-term clinical data have been gathered on the safety and effectiveness of this drug. Still, we don't know what the effects are of taking this drug for many, many years. Some people may end up taking this drug for the rest of their lives. Is this drug safe to take for 10, 20, 30 or more years? Also, what happens when you stop taking this drug? Many of you may know people who have taken the drug for a few months, reached their weight goal, declared success, and stopped taking the drug. Many recent studies have shown that as many as 60 to 80% of the individuals who are taking these drugs for weight loss quit within the first year. This typically results in the regaining of a substantial amount of the weight loss that they achieved while on the drug. In addition, stopping the drug may result in the loss of some of the other health improvements that were achieved, for example, with regard to blood pressure, blood glucose, serum lipid levels, and other health parameters. Still, even with the regaining of weight and the loss of some of the improvements in other health parameters, the remaining more modest improvements in body weight and cardioprotective factors may still mean that using these drugs for shorter periods of time has some important health benefits. But why do so many people stop taking this drug within the first year? Well, there are certainly going to be a number of factors, one of which has to be cost. Even the compounded versions of these drugs are not inexpensive, and many health insurance companies will not pay the full price of the authentic medication. The cost issue may improve as patents expire and as genetic versions of these drugs become more available. Also, insurance companies may recognize the healthcare cost benefits of encouraging their clients, to continue to use these types of medications. The other reason that many people may stop taking these drugs within the first year is, as I said before, related to the fact that they believe that they have achieved their goal and now believe that they can maintain their new reduced body weight without continued need for the drug. But research has consistently shown that regardless of the type and treatment for weight loss, when that treatment ends, people regain substantial amount of that lost weight. Which brings us to the final consideration. Should people expect that they may need to take this drug for the rest of their lives to achieve the true health benefit effects? Some researchers believe that that treatment of obesity is not unlike the treatment of other health issues that require lifelong medications. High blood pressure, for example. People who take medication for high blood pressure would not think to stop taking the medication once their blood pressure returns to a normal, healthy range. They know that they need to continue to take that medication for the rest of their lives. Perhaps obesity has to be considered in the same way. Of course, the idea of injecting yourself with a medication every week for the rest of your life may be difficult to accept. But as new and effective and safe oral versions of these medications are developed, and the cost to patients can be reduced, lifetime use may be feasible, and these medications may represent an important option in the treatment of the obesity epidemic.